Thank you so much. It's really great to be here. I never imagined I would be in a room with so many people having something so rare as my son when he was first diagnosed. And so it is really a great pleasure to meet you all. And even through the journey of autoimmune hepatitis alone, I know I reached out to several of you that gave me great insight to help navigate through our journey. But when Jennifer asked me to speak on Joseph, I mean, it's every mother's dream to speak on their child. You know, I can tell you all about how great he's doing in baseball this year and how he's a great skier and great student, but we can save that for another time because APS1 is just a fraction of who he is. And I know you see this overwhelming list here of diagnoses. I think I stopped counting at 16. But, you know, I look at it and I feel very fortunate because we were able to get a diagnosis very, very early. But I'll just give you the big picture of how it started for us and then move into more specifically autoimmune hepatitis. But when he was, you know, young, everything was perfect. He was healthy. Everything was wonderful until 6 months of age. He developed the thrush, the severe diaper rash, and then it was the nail dystrophy. His nails kind of flattened, stopped growing, fell off. And then the mysterious rash that I know several of you also experienced that went on for like 6 months. So I think we must have gone to 20 doctors at that point, between dermatologists, infectious disease, and I can't really fault anyone for not diagnosing him at that time because it was so rare. But we did end up going to Children's Hospital of Philadelphia, and we went infectious disease, and there was a young ID fellow who said, you know, I don't know why he has the nail dystrophy and the rash, but the candidiasis, that is something I think he might have APS1. I read about it in a book. And I was like, okay, so he did genetic testing, and there we got the diagnosis. So even as early as just a few things, we were able to get the diagnosis, which was devastating at the time, but wonderful because we were able to follow his labs over the years and catch all these things early. We never had really a crisis of any kind except once, which I'll lead into because it's related to autoimmune hepatitis. But, you know, you can see the list, the GI, the diarrhea, the constipation, the Sjogren's like dry eye. He has never shed a tear in his life. You hate to see your children cry, but I wish I was like, I wish I could see him tear, you know? But that was something. Addison's, enamel hypoplasia, eosinophilic esophagitis, which is rare. We did an endoscopy, didn't treat it, endoscopy in 2 years, and it was gone. So you just never know with APS1. Gastritis, colitis, vitiligo, you know, Addison's needing cortisol replacement, advanced bone age, which is also fairly rare in APS1. Usually it's delayed. And then AIH, and that was confirmed through the biopsy that we did, and following that, other diagnoses like diabetes, pernicious anemia, and growth hormone deficiency. But I'll just go, and I looked back at all the labs way back when he was young, 6 months old. And as you can see, the normal range for AST and ALT, when they're younger, maybe it's up to 50 is like the high, but it usually settles around the high being normal, 30. So as you can see, I mean, they were always high. Not too high. We always went back to, but as he got to like 4, it was double or triple. Then at 6 years old, it was several times higher. So at that point, because we were dealing with all the other things, we went to NIH, and they agreed with the liver biopsy. And at the time, we're seeing a fantastic liver specialist in Atlanta who was like, it's time. You know, he was being followed by him for 1.5 years. So he performed the liver biopsy, and the results did come back consistent with autoimmune hepatitis. And although over the years we did the liver-kidney antibodies, they always came back negative. But the liver biopsy did show that he had severe inflammation, chronic lobulitis, and moderate fibrosis. So we began treatment that next month. We started on 20 milligrams prednisone and 25 milligrams Imuran. And just a note for parents who start their patients on Imuran, it's always good to do the TPMT test genotype to make sure the patient is negative for it, because it's important that you're able to metabolize Imuran. The treatment complications started within 2 days, though, unfortunately. Joseph, who I always had to encourage to drink, was drinking so much. I noticed he wet his bed, and then a few days later, wet his bed like a lot more. He was up urinating. He was actually started begging me for water in the middle of the night and fill it up another glass, you know. And, you know, we threw it out to some nurses and all, and thinking, do you think he has diabetes? You know, but in the big picture of APS1, it's not really that common. And if it comes much later. So we didn't know it's a side effect, but then it got so bad that one evening my husband and I got an over-the-counter meter. We checked his blood sugar, and it was 600. So we got the A1C, it was 8.6, which is about an average blood sugar of 200. And after being at the NIH 4 months earlier, he had an A1C of 5.4. So 5.4 is not even pre-diabetic. It's like an average blood sugar of about 100. So it was pretty confusing, you know, is this prednisone-induced diabetes or is this type 1 diabetes? We began insulin right away, had insulin with meals and everything. And the question was, are we going to reduce the prednisone, and how quickly? Because typically you don't reduce it very quickly. You start high doses and maybe reduce it slowly over time. But we reduced it after seeing his liver enzymes were 21 and 31 in the hospital after 2 weeks on prednisone. We were happy with those results, so we just took a risk and went down to 5 milligrams. And on 5 milligrams, his liver enzymes did maintain, you know, stay in the normal range. We kept titrating down, you know, as quickly, but not so quickly as we could, and sure enough, on 4 milligrams. But then, as you notice in red, his liver enzymes increased. So we're like, is that an autoimmune flare? You know, what's going on? So it's really good when you're on Imuran, too, to test the 6TG, which is the therapeutic response rate. It needs to be between 235 and 400. And the 6-MMP measures the metabolites. And if it's higher than 5,700, there could be liver toxicity. So what we noticed there were some lab errors that couldn't get those readings at the 50 milligrams. But because we were reducing prednisone so fast, we wanted to increase the Imuran. And sure enough, as soon as we realized it could be the Imuran, reduced it back to 75 milligrams. And his liver enzymes just got back in normal range. So just as a parent or a physician, you know, always something to look at. And we've been keeping reducing over, it's been now 1.5 years. Joseph is down to 0.5 milligram of prednisone. It's almost kind of a joke. It's just like a little sprinkle. When my liver specialist is a transplant patient, he's dealing with 60 milligrams on many of his patients, you know, with steroids. So, but it's working for us, and that's the most important. Titrate down is where you can be to maintain good liver enzyme good control. So here we are today. Diabetes is now controlled on just Lantus, which is long-acting insulin, which is terrific because we don't have to do the meal insulin. So we feel very blessed to just have him on Lantus, but it didn't go away. So the conclusion is pretty much he had an underlying type 1 diabetes that was just unmasked by the prednisone causing the insulin resistance. And Addison's now is managed through a combination of prednisone and Cortef, and the liver enzymes are at a place I think is we're happy with, and we're just going to wait until next labs to see what the next step is. But that's our story, and I know everybody's story is so different, but I hope it may be of help to someone to hear it. So thank you so much.